And I came up with five, it's always arbitrary, isn't it? 5 things that came to my mind when I think about working in the trust. First of all, it's challenging. And challenging is one of those family therapy words, isn't it, like dilemmas you use when you're trying to put a more positive, Campbell-esque sort of spin on a situation. Other words would be exciting and endlessly fascinating, but bloody difficult to describe identified patients and family and professional systems which have been mired in stuck patterns, often for years. The second word that comes to mind is hierarchical. Mental health trusts are structured around hierarchies within and between clinical professions and modalities, with competition for status, resources and influence. Psychiatry has traditionally been the dominant profession, though individual psychiatrists are considerably more democratic and collaborative than they were when I was previously working in the NHS 30 years ago. There remains an expectation that psychiatrists are the clinical leaders, with the 3-year specialist registrar training implicitly and explicitly being a training for leadership as much as it is anything else. There is no such equivalent training for clinical psychologists or other clinicians. Some trusts also have a hierarchy of modalities of psychological therapy rather than a range with equal weight. For example, psychodynamic psychotherapy has been the most influential at the Tavistock Clinic, whereas cognitive behavioural therapy might carry the most weight elsewhere. Beyond the clinicians sit the managers. Unlike universities, where academics are also the managers, many parts of the NHS has gone for a general management model. This has many benefits, but can also lead to conflicting agendas between the managers and the clinicians. The stereotype being that clinicians emphasise patient need, and managers, taking a wider view, emphasise budget and targets. Another source of conflict lies between the medics and the managers about who's in charge, with the medics so far holding out against being managed by general managers. Psychologists might also prefer to be in that position, but without the power of the equivalent of a Royal College of Psychiatry, they haven't achieved that. As well as a professional hierarchy, there is also, as it were, an epistemological hierarchy, with realist assumptions about truth traditionally being the major influence underlying the practice of psychiatry, clinical psychology and much psychodynamic psychotherapy. Evidence-based practice talk is everywhere, emphasised by clinicians when the evidence is favourable, less so when it's not. And I include here family therapists, of course, who cite with relief, because at last we've got some gold standard research evidence, Leff et al.'s London Depression Study. Now, hands up anybody who hasn't yet so far not cited Leff et al. Depression Study. However, it has to be said that there's nothing stands still, and in the latest journal of family therapy is a critique by Gupta et al., who asserts that the data in that study is unreliable. So watch out. So in this sort of climate, it can sometimes seem discreet to keep any postmodern beliefs a bit under wraps. Third thing that comes to mind is that it's under-resourced. Pressure continues from targets such as the 13-week maximum wait for a first appointment, and too little money to fund necessary staff to meet such requirements. The Child and Adolescent Mental Health Services team, for example, in my trust, have been managing their waiting lists for a year or more by seeing only children who can earn themselves a psychiatric diagnosis. Other children with often quite severe difficulties can't be seen. Meanwhile, our own psychotherapy department, forced by government expectations, manages its individual and group waiting list by sleight of hand, by having a 13-week waiting list for a first assessment appointment, but you then go on to a second waiting list for actual therapy to begin, which can be as much as a year. Assessment is something that is sometimes all that can be offered. On the eating disorders unit, where I do 3 of my sessions, I can mostly only manage to do assessment of patients for the inpatient and day patient programs, rather than any ongoing therapy. And yet our eating disorder service, like many eating disorder services in the country, has an unfair wealth of resources in comparison with the general inpatient wards where psychological therapies on the whole are remarkable by their absence. To add to our difficulties, in my trust we are currently doing a service review following a requirement from the trust board to reduce the budget for psychological therapies by 30%, which is 230,000 out of a budget of 1.8 million. Familiar story to anybody? Mental health services money is rarely ring-fenced, and sitting as we do within the Thames Valley Area Health Authority, our mental health trust has had to subsidise heavy overspending in the general acute hospital, and in turn psychological therapies, as always, are seen to be the most expendable and subsidise psychiatry. I don't think my trust is exceptional in this respect, and in this difficult financial climate, the increasing numbers of designated family therapy posts in the NHS is a mark, I think, of how family therapy has come to be promoted and valued. Fourth thing, multiple models, and the core of what my talk's about. And the striking thing about trusts, I think, is the range of disciplines and therapeutic models found there. And I'm not going to go through the list, you can all imagine them for yourselves. But they do tend, within Sheila's ideas from yesterday, they can be either pure models or mixed models. So CAT, cognitive analytic therapy, for example, is a mixed model. IPT, interpersonal therapy, is another one. So mental health trusts are contexts which accommodate multiple approaches, what David Pocock has called therapy multiculturalism, with all the frictions and richness that implies. And the fifth point I wanted to make about trusts is system benefits. Yeah? So as a large system, a mental health trust has great potential to offer the most distressed patients and families in the greatest need a wide range of help and professionals helping them support in such difficult work. The existence of multiple models within a system which contains them well also offers potential for learning from others and a consequent movement towards increased integration across models. And I noticed that in Marlene and Rudy's new book, which I've not had a chance to read yet, but just flicking through the content, I noticed in there's quite a lot about integration, which I think is a new and interesting development. Okay, so before expanding on number 4, the multiple models bit, therapy multiculturalism, I just wanted to say that on a more personal note, of course, that a considerable advantage of organisations like the NHS, and just to refresh remember what I've been talking about so far. Remember I said that they were challenging, hierarchical, under-resourced, multiple models, and there are system benefits. But the other terribly important thing about trusts, the clever bit, is that they're full of chums. Which is a very important thing for me, having arrived in the trust 3 years ago after having spent a lot of time in private practice, and to have all these chums again. And of course chums can be within one's own particular modality, but also outside. And I thought when I was, I've talked about models on the whole, and I'm aware that 4 models read discourses. And I did think at one point that I ought to go back through the paper and cross out models and put discourses in, and then I'd sound more postmodern or something. And then I thought, well, I can't do that because then it would read chums. So it sticks as models and chums.